Good morning, everyone. Welcome to Pediatric Grand Rounds today. A couple of housekeeping items. Please remember to complete your evaluations, which are online next to your invitation. If you're anywhere close to the Tanglewood complex, we welcome you to join us in person on Thursday mornings. And for our many new attendings, remind you that Grand Rounds are qualify for maintenance of certification points as well. Please contact Megan Fouts if you have any interest, and she will help you get signed up. Today our speaker is Dr. David Eames, one of our soon-to-be graduating third-year residents. He came to us from VCOM, and to the best of my ability, he is still the only student that I remember who came very regularly to Grand Rounds, even when he was not stationed in either Roanoke or Pediatrics. His faculty advisor for this presentation is Dr. Kelly Henchel. Please join me in welcoming Dr. David Eames.
Good morning. So as Dr. Mishwar introduced me, thank you. I'm David Eames. I'm a third-year pediatrics resident, and today we're going to be talking about HPV immunization, best practices, and preventing cancer with that. So some objectives that we're going to go through today is about learning the history of the HPV immunization, reviewing the myths and common misbeliefs surrounding the administration of it or the contents of it, and then describing the best practices for immunizing patients, as well as understanding kind of the definition of what is considered a high-risk patient for HPV and the recommendations for immunization of these patients. So some disclosures, just briefly, in working with this, developing this, I worked with Dr. Henchel. We have no relevant financial disclosures, but we do have 4 children, 2 of which are hers that are fully immunized against HPV, and my 2 which are not, but need to be protected from it. Any mention of a brand name product in this lecture is not an endorsement, but it's just made out of simplicity because it may be the only product available on the market. All right, so a little bit of background about HPV and immunization of it. I know we just recently had a grand rounds given by Dr. Nickerson, who's one of our colorectal surgeons here at Carilion Clinic, and he went over some of the details of transmission and how the virus is actually transmitted and what it can do. But the background here is that in Virginia, based off of the National Teen Survey, ages 13 to 17-year-olds who report being up to date with HPV immunization across the country, Virginia kind of falls in about the middle category there in terms of its rates. And the reason why we want to talk about that is because, one, it's a required vaccine to attend the 7th grade, but it's actually a vaccine that any option that the parents want to list as being able to opt out of it, they're allowed to. So it's not something that's just reserved for religious beliefs or allergic reactions or things like that. Any reason why the parent wants to opt out of it, they're actually able to do so. And then how do we do in comparison here at Carilion Clinic with comparing ourselves to a statewide number? There is an ongoing QI project, systems-based QI project that is looking at improving the rate of HPV immunization in our primary care clinics, which is also something that my QI project gets kind of tied into. But for the fiscal year of 2020, we had a percentage of 42.3% of our 13-year-old patients that were seen for their well check during that year were fully immunized for HPV, whereas the number that we can compare that to statewide is actually an age range of 13 to 17-year-olds, but the statewide number was 64.9. So obviously, as you get a little bit older in that range, you're going to get, more of the patients captured there, but we are kind of a little bit behind when it comes to the statewide numbers. So why do we care, right? So immunizing against HPV prevents cancer, as we learned in Dr. Nickerson's grand rounds, and we reviewed that there. It's a nonavalent vaccine, protects against 9 strains of Gardasil, and we'll get into that a little bit more here in a little while. But it does prevent against cervical, vaginal, vulvar, and oropharyngeal cancers, and head and neck cancers as well. That's primarily the major cancers in females that HPV can cause. And then in males, you have oropharyngeal, head and neck cancers, anal cancers, and genital warts. But it's not just to prevent cervical cancer, which is a large myth and misnomer surrounding the administration of it, is that this is the vaccine that would go on to protect your daughter from developing cervical cancer, or your son's partner in the future from developing cervical cancer. The actual absolute number for HPV-related cancers in the U.S. By type of cancer from highest to lowest number in terms of cases per year, oropharyngeal is actually the highest, not cervical cancer. And so there's actually a chart here that compares and contrasts the average cases per year of the different types of cancers, and then the percent of those caused by HPV, and then the absolute number boiled down caused by HPV. And as you can see, cancers of the oropharynx are the predominant one here. 14,400 cases of that annually are contributed to or caused by HPV. And so when you look at cervical cancer, it's 11,100. So it's still right up there kind of with it, but definitely behind cancers of the oropharynx caused by that. Now we're going to go into a little bit of the history of HPV immunizations. In 2006, there was the quadrivalent, which protected against the serotypes of 16, 18, 6, and 11. It was targeted towards females ages 9 through 26, routinely kind of given at the 11 and 12-year mark. There's a 3-dose schedule, and then private insurance was really slow to cover this, so the rates of it weren't great in terms of private practices and things like that would only take private insurance. It was about $120 a dose, so that was also a complication to adherence with the immunization. Kind of moving forward, and we'll get to today's status with it, but in 2010 you had the development of the 2-valent one, and that covered against 16 and 18, recommended for females ages 10 to 25. And then in 2011 they added males to it. And then in 2014, you had the nonavalent, which is out today. And then as of 2016, the nonavalent, also known as Gardasil 9, is the only one that is distributed in the United States. So you still have 3 that are licensed by the FDA, but there's only one that's actually available to the market, and that's Gardasil. So Gardasil is a 2-dose series, routine vaccine at 11 and 12. For males and females. And it's only a 2-dose series if it's initiated before the age of 15. If you wait until after the age of 15 to give the first dose of it, it's actually a 3-dose series. But it's recommended through all people under the age of, or from the age, I think, 9 through 26, and you can start as early as 9 if there's history of sexual abuse or if the parent or guardian is requesting immunization for it. And so females age 15 to 26, males age 15 to 21, and then it's also recommended in 2016, they added a recommendation there for men who have sex with men as well as transgendered persons aged 15 to 26, and then as well as immunocompromised people, they would need the 3-dose series as well. So all of these people were required to get the 3-dose series. That's why the age group there starts at 15. So the current recommendation, as we've kind of come to in over those years, just to kind of sum that up, is that all persons aged 11 and 12 should receive a minimum of 2 doses that can be started at 9. There's a catch-up schedule for all persons through 26 years, if not previously vaccinated, or if incompletely vaccinated. The number of doses will depend on the age that it gets started at, and then their medical profile as well. So it's also still recommended for adults ages 27 through 45 as a kind of shared decision-making process based off of their medical profile, what their risk factors are. So it's also recommended to give a 3-dose series to people who are considered immunocompromised, and this includes conditions that might reduce either cell-mediated or humoral immunity. And so that includes your B lymphocyte antibody deficiencies, T lymphocyte complete or partial defects, HIV infections, malignancies, transplant patients, all patients with autoimmune diseases, and then immunosuppressive therapies. In this immunosuppressive therapies area, though, it does actually have an exception for people who are like on high-dose steroids or systemic steroids for short periods of time, such as asthma patients or patients who are requiring steroids for other reasons. So it doesn't consider those patients to be immunocompromised or receiving immunocompromising therapies. There's the dosing schedule to it, which is a 2-dose series, as we've kind of talked about, on a 0 and 6 to 12 month schedule for your immunocompetent patients. There's a minimum interval of 5 months between the first dose and the second dose. And then if for some reason the patient gets a second dose before that 5-month interval is up, they need a third dose, but they need to wait at least 12 weeks after that second dose, and to make sure that it's 5 months after that first dose. So let's say we have a patient who gets immunized on their 11th birthday and then comes back 4 months later due to maybe a scheduling mistake or whatnot, and receives a second dose of it. They actually need to wait now another 3 months until they're 7 months out from that first dose to get their third dose to complete the immunization series. The 3-dose series is scheduled on a 0, 1 to 2, and 6 month schedule. So you're getting about 5 months between that second and third dose there. And that's for all people, like we said, either initiating the vaccination series after their 15th birthday or fall into that kind of high-risk category. And so for that high-risk dosing schedule, again, it's going to follow that 0, 1 to 2 month, 6 month time frame. And we have, again, here listed the different disorders that would list somebody or require somebody to fall into that category, needing the 3 doses. So we're going to jump into a lot of different things surrounding the vaccine here and go over the adverse reactions. And it was my goal when developing this presentation to be able to make providers as informed and educated in terms of what are the true risk factors, what are the adverse reactions, what are kind of the concerns of parents that are out there today. Because as we all know, being a well-informed provider when recommending an immunization is the best way to have patient compliance with that immunization. There's no way to kind of overcome being behind the 8 ball when a parent brings up a concern that you're either one, completely unaware of, that may be out there in popular culture or media, and then having to kind of understand what that concern is and come up with a reason why it's invalid or whatnot. So being well-informed was my goal behind making this presentation. And so we're going to discuss a lot of the concerns that are out there. But in terms of adverse reactions, the most common adverse reactions to Gardasil are much like those with all local injections: injection site pain, swelling, erythema, and then you can also have headaches from it. Syncope is listed as an adverse reaction, but post-vaccination syncope has been reported at higher rates in adolescents and adults in all vaccines. And especially in adolescents, because you're waiting on kind of that autonomic nervous system to catch up to their actual skeletal growth. And so providers that give vaccines should consider having patients stay seated or in the supine position while vaccinated and observe them for about 15 minutes after getting the vaccine, which is recommended with the Gardasil immunization. And then systemic and serious adverse events were similar between placebo recipients and all vaccines that are licensed for HPV, including the Gardasil, which is the one that's out there now. So what are the contraindications and precautions to getting the HPV immunization? It is contraindicated in persons or people with a history of immediate hypersensitivity reaction to a component or to that vaccine. And then it is contraindicated in people with a personal history of immediate hypersensitivity to yeast, which is one of the additives or excipients in the HPV-9 Gardasil vaccine. The precautions for it, it has not been causally associated with adverse outcomes during pregnancy, but it is pregnancy category B, and it is not recommended to receive this during pregnancy. Excuse me. You're not supposed to test your patients if they're pregnant before giving it, but if you know that they are pregnant, you should not give it. And then if they become pregnant during that time span of getting the series, you should wait and defer all follow-up immunizations until after they give birth. So if you had a patient who came in and got the first dose of it and then came back for the second dose, but during that visit also reported having a missed period or whatnot, you should obviously then follow up that with, well, is there a possibility that you're pregnant, test for pregnancy, and if they are pregnant, then you should defer all vaccines for HPV until after they've given birth. However, they can get it while they're in feeding window there with their infant. And then there's also listed any exposure to Cerevix vaccine, which is discontinued as of August 2016 in the US, should be reported to the GlaxoSmithKline company. But we're probably going to be past this at this point because that hasn't been distributed in the US since 2016. And then kind of touching on what are the excipients and additives and are the contents of Gardasil or HPV immunization even controversial? As all of us know, being providers, when recommending vaccines, you have the vaccine hesitancy, patients and parents who don't want to give vaccines because of whether it be cultural beliefs, religious beliefs, or questions as to whether or not this could contribute to autism or other things. And so is Gardasil not even one of those immunizations that falls into that category? I didn't ever think that it was, and after doing all this research over the last 6 months to a year on it, it's not typically, and so it doesn't contain thimerosal, which is one of the excipients or additives contained in some immunizations that a lot of parents are concerned about because of its mercury content. And then there's, I believe, some papers that are out there that are not necessarily scientific that would recommend association between that and adverse outcomes. And then it does not contain MRC5 DNA or cellular proteins. It's not developed using those contents. MRC5 is one of the excipients and ingredients that is actually a DNA or cellular protein line that was derived from an aborted fetus back during polio, and it is sometimes used in immunizations, not the HPV immunization, to develop it. And so anybody who has vaccine hesitancy due to religious beliefs sometimes would be reassured to find this out, that it's not one of those immunizations. The excipients and additives in it do include aluminum, sodium chloride, histidine polysorbate, sodium borate, yeast protein, which is why it's contraindicated to give to people with hypersensitivity reactions to baker's yeast. And then there's no preservative or antibiotics included in it. So in touching on the controversies surrounding HPV, I wanted to put this in here because in recommending it, you may be faced with a patient or a parent who asks you about this. There is currently a lawsuit against the makers, Merck, of Gardasil. And as this is a screen capture from one of the law firms that's included in that lawsuit. And as you can see kind of right across the top there's probably some red flags that are jumping out at you, like the fact that it says free in more places than you care to see on the page. And then it lists the other lawsuits that they're involved in as well, including the Camp Lejeune water lawsuit and the 3M earplugs lawsuits. And then this is obviously published, this paper or information here is published by this law firm who is accepting patients and consults to represent them in a lawsuit against the manufacturer of Gardasil. But it actually, the lawsuit itself is stating that Merck, the company, advertised with basically deceptive research, and that some of the contents, specifically the aluminum that's included in the immunization, could have adverse outcomes for patients. So what does the CDC have to say about this? Well, aluminum-containing adjuvants are vaccine ingredients that have been used since the development of vaccines and have been used in them since the 1930s. There is small amounts of aluminum that are added to vaccines to help the body kind of build a more robust immune response and help prevent the patient from what that immunization is being given for. It's one of the most common metals found in nature and is present in air, food, and water. And this is actually, all of the words on this slide are directly from the CDC in a statement they made about a paper that we'll get to. But they are not recommending any of their vaccine schedules to change based off of the aluminum content in the vaccines. So, and my question surrounding this when finding out all of this is that, you know, a lot of us probably prepare our food using aluminum foil, and what sort of contact compared to a vaccine. And so in looking into that, our body readily absorbs aluminum through the GI tract most readily in comparison to any other aspect that we come into contact with it with, and there's a good bit of contamination that happens with aluminum foil, but yet we still choose to give that, and now people are questioning whether or not it should be used in an immunization. So there is a recent study that was published in September of 2022, so just a few months ago, that have identified a possible association between the aluminum from vaccines and later development of persistent asthma in a cohort of children who received those immunizations at healthcare organizations that participated in the Vaccine Safety Data Link. The title of the study is Association Between Aluminum Exposure from Vaccines Before Age 24 Months and Persistent Asthma at age 24 to 59 months. Obviously, Gardasil, being one of the vaccines that contains aluminum as an excipient, is not given to this age group, so it's kind of excluded there in terms of does it contribute to that risk factor for asthma being developed between 24 and 59 months. So the CDC is not changing its vaccine recommendations based off of this single study, but recommends that further investigation is needed to look into the potential safety signal for it. Excuse me. So going over kind of common myths and dispelling them, HPV immunization is not associated with any of the following autoimmune disorders, but has been recommended to be such associated in past in popular culture. So Guillain-Barré syndrome, there's no link or ties between administration of HPV immunization or Guillain-Barré syndrome. There's also no link between that and lupus or multiple sclerosis. Going back kind of to the aluminum thing, there has been studies out there that show Alzheimer's patients on postmortem autopsies have increased amounts of aluminum deposits in the brain. But again, the most common way that our body absorbs aluminum is through the GI tract, not necessarily through immunizations. There is no association there between blood clots and HPV immunization. Premature ovarian failure or infertility is not associated with it. Death is not associated with it. And then earlier sexual activity is also not associated with it. And there's a good bit of papers and research out there, as this is one of the most common concerns by parents, that I don't want to give this immunization to my child because HPV is transmitted primarily through sexual contact, and I don't want them to think that just because they've gotten this, that they're allowed to have sex. There's a good bit of research out there that suggests all patients who receive HPV immunization has looked at them, and there is no earlier sexual debut, if you would, for those patients. So what we do know is that early vaccination is long-lasting, and it has higher antibody levels when looked at in terms of post-vaccine status and their antibody levels for that when it's been given to the patient at an earlier age. So some people are actually making the argument to just go ahead and start the series at 9 for all of their patients at their 9-year well check, and kind of taking advantage of that fact that the body's immunity is still more robust at that point than when you immunize later on after the age of 15 or whatnot. And then this also allows for ample opportunity for the body to develop immunity prior to when the child or the person becomes sexually active. So HPV immunization does prevent more than 90% of genital warts, or could prevent more than 90% of genital warts, 70% of tongue and tonsil cancers, 85% of cervical cancers, 80% of anal cancers, as we talked about, kind of cervical cancers, oropharyngeal cancers, and anal cancers being your most common in terms of cases, and then 40 and 60% of vaginal and penile cancers, respectively. So, kind of touching on what is like the real world. So that's all. That was kind of moving now from all that basic science stuff over to what is the world that we live in now, and what are we protecting against, and who are we protecting against it. And so I worked with Dr. Henchel in developing this. So some of these pictures in here are hers, but the picture in the upper right side of the screen is a picture of her kids out at a basketball game. And I don't know what she was going to talk about with this picture. I know she's listening, but when looking at this PowerPoint last night, I was thinking about, okay, well, something I could talk about with that picture is, well, what risk factors did those kids have going to that basketball game, just like any of our kids when we take them out anywhere in public? You know, let's say one of them has to go use the bathroom. Well, as we learned in Dr. Nickerson's grand rounds, HPV can be contracted via fomite. It does not necessarily have to be contracted, although it's the most common way through sexual activity. It doesn't have to be contracted that way. So, in taking kids out in public, they can come in contact with it, and so we want to protect them against that. Obviously, our younger populations are at risk too with contracting it, as they're not eligible for the vaccine until they turn 9. But their bodies also do a little bit better with clearing the virus on their own, not necessarily holding on to the pathogenic viruses and the strains there. And then, the world that we live in now has social media, right? And so when trying to protect against sexually transmitted infections, as well as infections that aren't transmitted through sex, we do have to worry about all of the contacts through social media and the pressures that our kids are being subjected to these days. And what sort of information is out there on social media in regards to vaccines and their safety, or viruses and what they cause or what they don't cause, and misleading information that can be out there. This is another one of the slides that Dr. Henchel had developed, but she told me a little bit about what she was going to talk about here, and I think actually she got this as a screen capture from one of her friends, I guess, on Facebook, who had either liked or reacted to this post in some way. But this is actually a post about an Illinois teen who had apparently died after receiving the HPV immunization. I believe the patient went on to be diagnosed with ADEM, or acute disseminated encephalomyelitis, and later, I guess, died from that. But as we know, after reviewing the adverse reactions and kind of the associations and myths about what is associated and what's not, ADEM is not associated with HPV specifically. And so this was one of the slides that we just wanted to show. There is information out there in popular media that's not accurate and is very misleading towards our patients. So some of the other things that you may encounter, or hesitancies that you may encounter in the clinic, include, patients who say, or parents who say, well, we don't need to worry about that. That's transmitted through sexual contact, and because our religious beliefs, we don't need to worry about that for our son or daughter. And so, and just kind of thinking about this statement, it's not necessarily consistent, right? So I think most religions believe in the fact of whether or not there is sin, and that we live in a kind of fallen world. And so to think that any child or person may go forward if they're quoting their religious beliefs as being the reason why they're not going to fall in line with the vaccine, I don't know necessarily, but most kids I don't think are perfect. Mine certainly aren't. So let's try and protect them from what it is, the sin that's out there, that if they may fall subject to it. Certainly what is the risk behind it, and what is the risk of them eventually having sex? Well, most people go on to eventually have sex. So let's go ahead and protect them from it while we can. Could be good talking points to kind of go through with parents who are quoting this as one of their concerns. So there's also good news out there about it. We are learning more as time goes on with immunizations. And we know that it's not necessarily what you say, but kind of how you say it, how you recommend it. And then, what are ways that we can improve our vaccine rate, specifically here at Carilion, but also kind of nationwide, as a lot of us are going to be leaving here after residency and going on to other places to practice. And what do we know about the methods and procedures or policies that help clinics improve their vaccine status specifically for HPV? And that is to include a standing order for patients when they reach a certain age group to go ahead and have that standing order and the EMR to be placed so that providers are not forgetting about it. And then making sure there's no missed opportunities to give vaccines or immunizations, including HPV. And then making sure all of our staff in the clinic and that work with us are educated on HPV immunization and its risks or benefits. And if we have one person who works in the clinic that knows all there is to know about it, but yet the clinic has 50 employees, well, those 50 employees know a lot more people than that one provider can come into contact with. So we know that if we educate all of the people that work there, who may be having conversations outside of work or even inside work about certain immunizations or risks or benefits of that immunization, then having everybody kind of educated on that is going to improve your patient's kind of willingness to obtain that immunization. So there is a American Academy of Pediatrics HPV Champion Toolkit online. There's also the CDC website, which has most, if not all of this information on it. And then there's the American Cancer Society out there that also talks about HPV and the prevention of cancers caused by HPV. And then locally, we do have the Virginia Health Innovation Network with the Virginia Vaccinates campaign on there as well. So the AAP's recommended best practices for HPV immunization, there is actually a whole equip module on this, which is the QI, kind of, I think, CME stuff and resident education that's listed on the AAP website. One of the main things that talks about is availability. And so to maximize your immunization opportunities, you should think of every encounter as an opportunity to encourage vaccinations, and every office visit as an opportunity to go ahead and immunize. Excuse me. And this approach is particularly important when dealing with adolescents because they're not in the clinic as much as we know. So I know at least in our continuity clinic, and maybe this is kind of selection bias because we have an adolescent clinic here, but we don't see too many adolescents. And a lot of pediatric practices fall into that same group, believe it or not, because the adolescents aren't as loyal as coming back for their well checks as parents are to bring their young children in for their well checks, and so you get less clinical encounters with them. Some of those clinical encounters are primarily for adolescents, include your sports physicals, as well as sick visits and things like that, because that's when we find that the adolescents are coming into the clinic. And so they do recommend giving patients these immunizations, or all of their immunizations, specifically HPV included, at any office visit if there's not a contraindication. And so that includes well visits, sick visits, vaccine-only visits, and then also allowing for walk-in vaccine-only appointments if it's offered by the practice. And then they also recommend checking the immunization status of all of the siblings that accompany either young children or other siblings that are older maybe. If you have somebody that's coming in for a sick visit and they're coming in with their 12-year-old brother, check the immunization status of the 12-year-old while you're there so that you can go ahead and offer the immunization to that person even though they don't necessarily have an appointment made. Some of the other things that EQUIPS talks about is office hours. And so if you don't have office hours that mimic the lifestyle or mirror the lifestyle of your patients or their parents, it's going to be difficult for them to get to appointments, keep scheduled appointments, or arrive kind of on time to their appointments. And so in an attempt to improve vaccine rates, you could consider offering appointments and time slots that kind of fit the middle-aged parent or working parent's lifestyle. So appointments before 9 a.m., appointments during lunch break hours, and then appointments after 6 p.m. And then also, in terms of office scheduling for the immunizations, you could consider vaccine-only appointments as either same-day appointments or even reserving some time slots for well checks, even in acute clinics, after-hours clinics, and things like that. Parental consent is required in the state of Virginia for teens to receive immunizations. And so when a parent calls to schedule the appointment, you could consider obtaining verbal consent over the phone with a witness at the time that they're calling in, so that then if the teen does show up on their own, if they're old enough to drive, or if a grandparent brings them who's not a medical decision maker, you already have consent, and so you don't fall subject to, saying, oh, well, you're not here with your parent, we had to get consent from your parent to give this vaccine, so go ahead and obtain that when making the appointment. And then standing orders is also something that's discussed a lot with HPV immunization and immunization for teens. And so that allows all eligible staff to go ahead and administer the vaccine to a patient of the clinic who meet the specific criteria to fall into that category. And then that prevents kind of interruptions to your schedule during the day. If you're seeing patients and somebody calls and wants the vaccine, the provider doesn't have to take time out of their schedule to go ahead and make another slot, or go ahead and put the orders in for a patient who may only need to see a nurse or a staff member to go ahead and receive that immunization. So it kind of speeds up the process for providers. And then the CDC actually has a top 10 tips for HPV vaccination success. And so we're going to go through those, and they're not in specific order, but they're just listed bulleted in terms of numbers. So I could show you that there's the 10 out there that they recommend. And number one is to appreciate the significance of achieving a high HPV vaccination rate in your clinic. And so, as we've talked about, HPV immunization does go on to prevent cancer. And so knowing that you're doing that for your patients and acknowledging that that's the reason why I'm giving this immunization is pretty significant. We don't give many immunizations that we can say, well, this prevents cancer later in life, so we're going to protect your child from getting cancer later in life right now. And then acknowledge the importance of your recommendation to the family when it comes to choosing to vaccinate their child, right? And so clinician recommendation is the number one reason that parents decide to vaccinate, and that's for all vaccines. And this is especially important for HPV vaccine because the patients or parents may not know that it exists. It is not something that has been out necessarily as long as some of the other vaccines. And so parents may not know or be familiar with HPV immunization because it may not be one of the ones that they're used to turning in proof of their immunization status at work or whatnot and saying, I got this, I got that, here's when I got it, like we are with necessarily like MMR or Hep B, DTaP, and so they may not know. So your recommendation to go ahead and get it may be their first time that they've heard about it. And then using an effective approach by bundling your vaccine recommendation. So let's say, they're coming in for their well check, and this example gives Danny as an 11-year-old, and so he's going to be saying to the parent, he's going to be due for vaccines to help protect against meningitis, HPV, cancers, and whooping cough today. So we'll give these shots during the visit and asking if they have any questions about it. So instead of going through each individual one or saying, well, the ones that they're due for are, and listing off the ones that are recommended, that's kind of what we consider routine, and then saying, and then the optional ones are, so they recommend eliminating that from your language. And then also in the state of Virginia, it's not necessarily optional, it is one of the required ones for school. So eliminating any discussion of that as well. It's gone on to prove to be more beneficial in vaccine rates among patients. So motivate your team and encourage their immunization conversations with parents. Ensure each team member, like we were talking about, everybody that works in your clinic should be aware of the HPV vaccine and its importance. And so that's something that's going on here with our larger systems-based QIs that we're getting, I think, clinic champions from each one of the Carilion Children's Primary Care Clinics and sites that's going to take on educating the members and staff of each one of those clinics about the vaccines practices and best practices and recommendations. And make sure that your staff is ready to answer kind of difficult questions when it comes to vaccine status in terms of what's recommended and who it's recommended for. And then be sure that staff regularly checks immunization records, places calls to remind families about getting vaccines, and letting the providers know if parents have additional questions that they weren't able to answer. And so I know some of our clinics work on a pre-charting by the nurses versus pre-charting by the providers, but making sure that somebody is double checking all of the patients every time you see them in terms of their immunizations and who's received them and who has not, so we can figure out who needs it and who doesn't. And then implementing systems to ensure you never miss an opportunity, right? So establish a policy to vaccinate at every visit, and reviewing during your pre-charting who for that day does need to catch up on these vaccines. And so before you see the patient, will help improve your time of seeing the patient if you've done that beforehand. And then they also recommend using your local health departments as a resource to achieve your goals and protecting your patients. So if the patient, if your clinic is not able to, like if it's not a vaccines for children clinic where you can give vaccines at a cost-effective rate, then you can send them to the health department where they can obtain all their vaccines for free. And then knowing your rates of vaccination and vaccine refusal. So if you don't know that there's a problem within your clinic, or you don't know that your vaccine rate is lower than the average, you won't know that there's an issue there that needs to be addressed. So kind of knowing about your rate and what it is will help you improve it. So you can kind of deputize your staff to assist you with knowing that, and then learn more about why some patients are behind on their vaccines and finding out if there's hesitancy there. And then they can also help you to facilitate solutions on how to bring these patients in and get them immunized and keeping their immunization rates up. Number 8 is maintaining a strong doctor-patient relationship to help challenging immunization conversations. And so this is probably one that we've all encountered when you have a vaccine hesitant parent. I'm just going to X out of that. I don't know what that is. So maintaining a strong doctor-patient relationship to help with challenging immunization conversations, and having come into contact with parents who are vaccine hesitant, and being able to talk to them and address in kind of a non-judgmental manner, what is your hesitancy? Do you mind if I ask you about that? And just so I can make sure that we're on the same page as to why it is you're refusing this, and acknowledging that they are the parent and they do have the right to refuse any medication or immunization for their child is sometimes a way to kind of softly open that door, and then say, but I would love to know what it is that is causing you to be hesitant about this immunization in particular, so that once you know what is causing the parent to be hesitant about it, you can address that issue. Being a well-informed provider, like we talked about, is the best way to do that. So no matter what it is that they're bringing up, you're kind of already prepared and equipped, if you would, to go ahead and address that concern or manage that hesitancy. Number 9 is, learning how to answer some of these patients' most common questions. So being prepared to answer the questions concisely and empathetically by using terms that they understand. And then, a parent will often accept your explanation if presented with their child's best interests. So saying, addressing their concerns or their hesitancy, and then going on to say, I don't necessarily have a vested interest in whether or not he gets this. I'm just looking out for his health in the long term and trying to prevent him from, or her from, developing a cancer that they may not have to go through having later in life because they got this immunization. And presenting it as something that's for their child's best interest has also been shown to help improve your rates. And then lastly, they actually recommend using personal examples of how you choose to vaccinate all the children in your family, and how you recommend it to your family members to vaccinate their children as well. So providing personal examples shows that you believe in the importance of immunizations, especially the HPV vaccine. And then those examples, combined with an effective recommendation and knowledge base by the provider, can help parents better understand the benefits of it, and can help give more vaccines to prevent cancer. So those are the 10 recommendations by the CDC. And it looks like it came up a little bit short on time, so I might get out of here a little bit early. These are some references that I had for the presentation. And then actually, kind of going off of number 10 there and using personal examples, I wanted to talk about what is my personal experience with HPV and choosing to immunize patients with it. So the picture here on the far right portion of the screen is actually a picture of my sister, my older sister, who at the age of 29 had a HPV caused cervical cancer and had to have a complete hysterectomy. And so as you can imagine, a female who's 29 still in that kind of childbearing age, right, and wanted to have more kids, but may not be able to if they develop a HPV cancer and have to have removal of that cancer. And then these are also just other pictures of my family, my 2 daughters, who, obviously will be immunized against HPV in the future because they're not old enough to now, but wanted to make sure that they don't fall into that kind of same poor outcome that my sister had to suffer with. So, are there any questions or comments? Yeah.
Dr. Kreider said, did you find any associations with POTS syndrome and HPV?
No, I don't know that there is specifically a HPV immunization. Is that what she's asking about, or HPV?
She just said, did you find any associations with POTS syndrome and HPV? This is the newest concern patients have raised with me. Immunization, she said.
Okay. So no, but that kind of falls back into that whole, adolescents and adults. We're looking at the side effects of the vaccine or adverse reaction. Adolescents and adults all are kind of at an increased risk for syncope when having immunization. But I don't know that it going on to cause POTS, if there's been any causality relation there. I didn't find anything on that either when looking in popular media.
I'll make sure people don't leave too early because I got a few comments. I think first, that was a great presentation. It was a nice review for everybody to see. I think you referenced Dr. Nickerson's talk a couple times. I was trying to find out if that's up on our YouTube site or not. It is, for those who missed that one, that was phenomenal. You mentioned about fomite spread. He also talked about that, that it's spread through squamous cells. Anybody in here want to raise their hand if they don't shed squamous cells? As he pointed out, everybody sheds them. They can, and the HPV that's present in them can stay alive for 7 days. I found also his talk was intriguing that in the colon cancers, they're finding genetic material for HPV, not just the anal rectal, but the colon cancers higher up in there. It was amazing to me. A little at the very beginning, you mentioned data for here, as I think you said 43%, and we were looking at maybe apples to oranges. Although, since I'm sitting next to Kim Kinzer, we did look at, and I don't think we ever finalized it, but we looked at the question, what was our vaccination rate as we went up to about 17? And Kim, unless I'm incorrect, we didn't come anywhere near that 65% there. Yeah.
And then
we might have tweaked up a little bit, but just we locally looked at it. And then I'll stop after the third comment. The third comment that just dawned on me this morning as I'm coming in to hear your talk was, we look at this one, and HPV, it doesn't affect us. It affects the 29-year-olds, as you put out, It doesn't affect my 17-year-old that I'm taking care of. But I wonder, I don't think we've shared and looked at what's the lifelong risk of incidence and mortality from HPV-related disease. Compare that to something like that's tangible to us that we easily get buy-in and selling is meningococcal. I wonder what the incidence on that is. I bet it would be a bit an astounding.
I read an article over the last several weeks, and it was about reintroducing HPV back into the visits because it's been overlooked with COVID. And it was interesting because, the Tdap and Menactra are required for school, but long-term when you're looking at outcomes, there's very few people who die because of the components in tetanus and Menactra. But then there were I think it was 8,000 deaths a year related to HPV. So you should give it higher priority because by giving that one perhaps first, you're going to have a better outcome long term.
I think you're calling how many of our patients will never have sex.
Never.
Depends on who you ask, the parent or the child.
But never.
I would think, but with vaccines in general, we tend to give the vaccine before the child or the patient reaches that age group where they're at risk for developing the disease caused by that, right? So it kind of falls into that, kind of line of thinking that you were mentioning there. And like you said, most of our patients do go on to have sex, and I think we have some pretty good providers here, so most of our patients do go on to reach the age of 29 also. So if we're planning on our patient being alive at 29, we might want to help them out a little bit earlier on in life if we can prevent them from having a poor outcome at the age of 29. Yeah.
Did you come across a lot of literature on the influence of social media in our decision-making capacity? I know they've studied that a lot with other things like SIDS and sleep surface area and things like that. Any major?
I didn't find any literature on it. I'm sure there's some out there. I didn't specifically look for that either. Just kind of touching on the social media aspect of it in the presentation. I didn't look into see if there were studies out there that looked at what is the kind of the vaccine or vaccination rate of people who have come in with, concerns to the clinic prior to getting it, prior to recommending to get it, that have come into contact with that stuff. Most of this stuff that's out there in terms of popular culture is a lot of videos of bloggers or whatnot. I know one was recently brought up from somebody who's really popular in politics and social media and talking about HPV going on to cause her personally to have seizures and whatnot. And so it would be interesting to see if there's studies out there that look at those numbers to say, is there a lower vaccination rate or vaccine acceptance rate, if you would, to people who have those concerns. But I think talking about and knowing if you have providers who are well educated on what are the actual risk factors, what are the actual contraindications, and what are the actual ingredients and whatnot, you're going to have better conversations with parents and patients who are concerned about these things and probably be more convincing to the patient and parents to go ahead and vaccinate.
There's a lot of work on that, because I think what they're saying is the patients don't care about the concrete issues. They have certain things in their mind, and they do somewhat point the finger back at the medical providers and how we present vaccines. We never walk into a room and say, are you ready for your Tdap? Are you sure? Do you want to do it today, or we can wait another year when you're ready? We never do that with meningitis or polio, but we do. We do somewhat vary our words and how we present things with confidence and with surety. And so a lot of the finger pointing comes back to the medical profession, in that you may be leaving some room there where it's judged that
How you said it.
and how you say it and present it, that you're not fully confident behind this vaccine. And a lot of hesitancy comes from that. If my doctor isn't sure, how can I be sure? So
Flu immunization rates, there's stuff out there about that and how that's presented, with just lumping that in with, well, yes, today they need their 12-month shots that include MMR, varicella, DTaP, and flu. And not listing that as like, oh, well, they need these, but did you want a flu shot today or do you not?
a lot of opting out instead of opting in. So.
Another thing about presenting the vaccine, to be persuasive, the slide you showed, HPV prevents more oropharyngeal, much more than sexual part, like a vulvar and penile cancer. So this is maybe a good strategy when you present the cases, also because the most concern is starting sexual activity earlier, and they prevent the other ones also, right? So.
And actually, something else to point out there in relation to that is that those top 10 tips and the AAP's recommendations on improving your vaccine status, nowhere in any of that does it talk about you should mention sexual activity or sexual contact as a transmission, right? And so just listing off, this is, if somebody asks, what is the HPV immunization for, say this is the immunization that protects against a virus that we know causes cancer. It causes cancer of the anus, the rectum, the colon, the oral pharynx, the cervix in women, the penis in men. Nowhere in there do you have to mention that it's spread by sexual contact, and which opens up a door for the provider that they don't probably want to open during a 9-year well visit.
Don't mention the word sex. No parent wants to have that in their mind at all.
And I was going to say, I think that's a big deal, is when it first came out, it was more talked about like it was for sexual activity. And I remember when my kids were that age, I was not thinking about them at 9 and 11 going on to have sex, but I think the big thing now is just saying that it prevents cancer.
I think when it first came out for women only, that set the stage
Yeah.
for a sexual discussion. And that
Well,
it-
men don't have sex, so.
And that it was targeted for the cervix kind of has that implication. And I've used that with the parents. I said, hey, this is, we shot ourselves in the foot with this, but look at what it really is.
Yeah.
All right, well, thank you so much, Dr. Eames.